Outflow tract ventricular arrhythmias are the most common type of idiopathic ventricular arrhythmias. They typically occur in young patients. Differentiating between right ventricular outflow tract and left ventricular outflow tract origins of ventricular premature complexes or ventricular tachycardia is a fundamental task in clinical electrophysiology, as it dictates the procedural approach, whether you should go by the venous approach or by the arterial approach for catheter ablation. Since both outflows are superiorly located, both typically present with an inferior axis, meaning that tall R waves in inferior leads 2, 3 and AVF. The primary differentiation lies on the horizontal plane, that is precordial leads. 70 to 80% of outflow tachycardias originate from right ventricular outflow tract. Small numbers can originate just above the outflow tracts as well, like aortic cusp ventricular tachycardia. We'll have a look at general morphology rules. This is known to almost every student of cardiology. Basic pattern is left bundle branch block for RVO2 origin. That's because of delayed activation of the left ventricle, as occurs in left bundle branch block also. LVO2 origin, RBBB pattern or a typical ABBB pattern. V1 morphology, deep S wave, smaller absent R wave in RVOT origin, again the LBBB pattern. In LVOT origin, in V1, tall R wave and smaller S wave. Transition lead, usually V3 or later, V4, V5, in RVOT origin, and usually V2 or earlier, V1, V2, in LVOT origin. And lead 1 usually positive leftward when there is an RVOT origin, often negative or isoelectric when there is an LVOT origin, all based on the location of the LVOT and RVOT, as you can see in the echo picture. When the transition occurs at lead V3, simple observation is often insufficient and specific indices are used to refine the diagnosis. V2 transition ratio. This is a highly reliable metric. It is calculated by comparing the R wave proportion during the arrhythmia to the R wave proportion during sinus rhythm. V2 transition ratio is equal to R wave divided by R plus S of the PVC and the whole divided by similar metric of sinus rhythm, that is R by R plus of sinus rhythm complex. A ratio more than or equal to 0.6 strongly suggests LVOT origin. When is less than 0.6 suggests RVOT origin, again based on the direction of LVOT and RVOT, which side the R wave will be dominant. V2S by V3R ratio compares the S wave in V2 to R wave in V3. A ratio less than or equal to 1.5 is indicative of an LVOT origin. R wave duration index measured in lead V1 or V2. It is the R wave duration divided by QRS duration, showing that how much of initial activation is there. If the ratio is more than or equal to 50%, suggests LVOT VT, specifically aortic sinus cusp. That's what we mentioned earlier. Some VTs originate above the outflow tracts. R by S amplitude index, again measured in lead V1 or V2, more than or equal to 30% suggests LVOT tachycardia. Please note that these are only generalizations based on some studies. Actually, there are several sites of origin within RVOT and LVOT with different ECG morphologies. Anatomical correlation. As mentioned earlier, RVOT is located anterior and leftward relative to the LVOT. Anterior structures, that is RVOT, produce a late transition because the depolarization vector moves away from the anterior leads V1 to V2 initially. Posterior structures, that is LVOT, produce an earlier transition, taller R waves in V1, V2, because the vector moves towards the anterior chest leads from the beginning. Then there are certain site-specific nuances within the RVOT and LVOT. As mentioned, there are several locations within each outflow tracts with specific reasons. RVOT septum versus free wall. Septal origins have narrower QRS. That's because it reaches the conduction system earlier and earlier transition compared to free wall origins. Aortic cusps of the LVOT VT, left coronary cusp often shows a W or notched pattern in lead V1. Right coronary cusp can mimic RVOT septum but usually has a taller R wave in V1. Mimicking RVOT because right coronary cusp is quite near the RVOT. Please note that the intimate and complex anatomy of the outflow tracts limits predictive value of ECG criteria alone for localization of these arrhythmias.